Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Welcome back, everybody. Today we have with us Dr. Becket Mahnke, who I am delighted to interview today because for a lot of you, you work within the Epic EHR system. And so we're delighted to hear some of his progress in the area in related to efficiency. So welcome.
Thank you very much, Sarah.
I'd love you to introduce yourself to us. Tell us a little bit about you.
Great. So I'm Becket Mahnke. I am a practicing pediatric cardiologist, although just one day a week these days. I have been doing informatics work since before we even knew what informatics was. But in an official title, probably for about 15 years. I've been a CMIO at now 3 organizations over the last decade. And I've been here at Confluence Health for about 5 years.
There we go. And you've done some amazing work inside is it EHR or EMR? What do you guys call it?
We do both. It
Okay,
really
good.
depends. Yeah.
Just checking, 'cause I've used both as well, and I feel like a bit bilingual there and wasn't sure which was the correct term. Before we dive in there, do you want to tell us a bit about why you chose cardiology, your a little bit about medicine for you and its effect and the sustainability and why informatics became important?
So I went into pediatrics because I can't imagine a better cohort of patients to take care of. And that's selfish, but I get the most out of taking care of a patient who can have a multi-decade lifespan and contribution. Cardiology is just, the most fascinating portion of that. And when I finished my training over 20 years ago, um, one of my friends and mentors, he was my boss at the time, said, "Hey, I'm going to protect about 10% of your time, and you're going to do some telehealth projects. By the way, here's the grant you're going to apply for, and oh, it's due next week." And I said, "Thank you very much." And I knew him quite well, and he's a great friend. Um, and what happened over time, over really the next decade, is I'd gotten several grants for developing both telecardiology projects and then telehealth projects. This was when I was living in Hawaii. And when he left the organization, I was fortunate enough to take over the telehealth program. Fast forward, about 5 or 6 years, there was this thing called the American Board of Preventive Medicine, who was sponsoring the clinical informatics board certification. And a good colleague of mine said, "Wow, we should actually apply for this. Turns out we've been doing informatics. We just thought it was our work, but it turns out we're doing clinical informatics." So that was in 2014, and then retired from my Army career in 2016. And at that time, I was about half-time clinical and half-time informatics, and decided I wanted to, see if I really wanted to flex those informatics muscles even more. And that's when I started on my chief medical information officer journey. And it's been fascinating. I've been at 3 organizations. All 3 of them have used Epic. I've learned a lot about technology, Epic in general, how software is developed and deployed. But really, I was probably one of the loud complainers when we transitioned from paper to an electronic medical record, because ultimately, I don't really care about the newest, coolest thing. I want to ensure how we can deliver the best care for our patients in a way that allows our providers to be present and satisfied and want to continue practicing their profession. So that's the goal in mind. I have the privilege of meeting with all new providers, and we bolus them twice a year. So we just had our 6-month group last week, and I get to sit with all of them and try to frame their staring at a computer in a way that's positive. I said, "Listen, I want to minimize you looking at a screen because I want you focused on your patient. And you only have so much brain power when we're taking care of patients. And I want as much as possible going to the practice of medicine, and I want to work to minimize that other cognitive burden so that the care is better, right? And that's what you went into this for. So that's always been the focus. And the cool techie stuff sometimes is kind of fun and geeky, but we have to remember what the point of all this is.
Yeah, yeah. I like to say that the EHR was not designed for us. I do think it feels very much like there's a lot of steps to get somewhere. There's a lot, it's like as if it was designed for the people watching over us to see how, what we're doing, how the patients were looked after, how long it took. But the flow through some of these work throughs just
Yeah.
took so long, and I agree, it could be that becoming familiar with it, and we've certainly had physicians using it for decades now. what I'm it, you've done some work, and I love this. I want you to be present with the patient, and it's like, that sounds amazing. How do we do that?
So I might challenge that they were designed by not by us. I think the challenge is that they've been designed by all of us. And
Uh-huh.
one of my old boss's sayings was different practices have different practices.
Mm,
And the trouble is all that variability has created a software platform that there are 12 different ways to do something. Uh,
yeah.
I also give not just Epic developers, but the developers of these systems some grace in that they developed it because somebody asked for it.
Mm,
And that's the problem. So we've got, 12 different ways to do something and we want to pull our hair out, right? So one of the principles that we have, and my team, I try to empower my team with guiding principles, my informatics teams, um, is that listen, the vendor will give you this many ways of doing something, a broad spectrum of ways of doing something. That's great for them. We're going to focus on these methods, right? So there may be 10 different ways for me to remind somebody that they are due for some sort of cancer screening, right? And not remind you like doing your job, but really providing what gets a bad rap, but true clinical decision support, right? To assist you. There's 10 different ways of doing that. We have one way of doing that at Confluence, right? So I may have a specialist who comes in and says, hey, I want to screen for this disease, or I want to remind folks eh, to do this, and I'm going to use this tool. And I say, wow, that's wonderful. We're not going to use that tool because here at Confluence, our style is for all of that type of decision support, we use this tool, right?
mm,
So that it's all there. It's not 10 different lists that I have to go check, like all of
yeah.
us are inundated with different communication channels. We say, listen, we're going to do our health maintenance through this channel, and that's where we're
Mhm.
going to put it. And by the way, the person that gets to decide if we're going to put that reminder there is not the specialist, it's the person on the receiving end, right? So I take that analogy from a concept. There's a great book put out by a Stanford physician called The Digital Doctor. And he gives the analogy that every year at Boeing, let's say, all the engineers of the different systems on the plane come in and they say, hey, this is our system. And we've got this little red light we want to turn on in the cockpit. And who gets to decide if that red light comes on? It's the pilots. It's not the people building the system, right? So in many cases, I might have a specialist who's very passionate and primary care says, nope, that's not the most important work for us.
Yeah, I think this is important that the somebody, and I like the idea that somebody's thinking about the end user and saying, how do we minimize the number of buckets they have to go look at?
Yes,
How do we decide the way we work with our system flows so that if somebody's due for their colonoscopy screening, the whole team can know that and not just the doctor? Um,
absolutely.
so it doesn't become physician work or clinician work. It can actually become the team looking after them's work, bigger than you. Um, the systems we work in where I have to remember to look at that reminder and that reminder and that reminder. You're right. Things get lost because you're so busy trying to understand what the patient need is today and doing all of that high level work for the patient The last thing you want to do is look at the bells and whistles going on about them
Right.
in there.
And one of the things that I'm particularly proud of here that I get to participate in, I don't lead this particular work, but my wellness physician leader, Dr. Shanbor, has been leading us through the American Medical Association's Joy in Medicine program. And it is a very nicely laid out roadmap with several categories. I participate in two of them, that allows you to progress an organization from a wellness standpoint. And the two I uh, participate in heavily is efficiency of practice, which we can come back to, but also the teamwork aspect. So we measure at the specialty level, department level, and even at the provider level. And when I say measure, not to be, big brother, like, oh, we're watching you, but to ensure that we're providing the best system. But we measure teamwork, right? And there's one way of measuring teamwork is how many orders were started by somebody else on your care team, right? Because I'm sure that in the paper days, you may remember, um, I didn't write a lot of orders. I sign 100% of my orders, right? But somebody teased those orders up. So a lot of our routine health maintenance and screenings and chronic disease management, A1C testing, and those things, we expect those orders to be put in by the team, obviously with the team captain as the responsible and signing authority.
Yeah, I love that.
Yeah.
I love
So we
that a
do a lot
lot.
of work around that. We just achieved the gold status, which is the highest status in the Joy in Medicine, and we're ecstatic that over the last 5 years we've been able to progress that work. The other piece has been the efficiency of practice, which is measuring, and we're data obsessed here, and that's largely because I'm a nerd. But we are data obsessed on reviewing the usage of our EHR.
All right, let's talk about efficiency in practice.
Um, we are data obsessed here, largely because I'm a geek and I don't mind, looking at that. But it's really an objective way of having conversations, right? Part of, I tell any junior informatics provider or nurse that half of our job is just listening to the challenges, right? Because that's an important part is to get that off their chest. But then to take an objective approach like we do in medicine, right? And bringing that same context, I tell people I diagnose and treat people that are working in our system. And it's not that they have a true disease, but that framework allows us to say, okay, let's look at our diagnostic tools. Let's look at the data. How are you compared to your people that work in your department? Because in theory, you're working in the same system, right? So how can we improve that? So we look at we regularly look at time spent in the EHR per appointment per day. We look at our after hours time or work outside of work, whatever you want to call it, pajama time. And we track that over time, realizing that there's both a average number there, but one of the things I realized many years ago is that the average doesn't tell the story, right? Average, is useful, but when you see the distribution in a clinic, so I was in my cardiology clinic years ago and we pulled up our after hours work data by provider and we were all transparent. We said, let's look at this together. This is information to get better. It's not information to shame or criticize. And one of my colleagues who was on the far right, which was spending a lot of hours after work, looked at one of the providers who was spending no time outside of the office hours. And he said, I need to come hang out with you because you are obviously succeeding in this system. I'm going to hang out with you. And I had the biggest smile on my face. I was like, that's exactly what I expected to happen is to learn from your colleagues. And we've been focusing on these bright spots, people that demonstrate that you can succeed with the tools. And how do we get folks there?
Mm-hmm. Yeah, that's really valuable watching somebody else's workflow. I think when we had the rollout of the Epic system within our hospital system, they brought in super users, somebody who's been familiar with the practice, and they weren't familiar with your practice, so they couldn't give you all of the hints and tips and tricks, but they were at least able to watch how you worked and said, no, this and this would make it easier, less key strikes to do it this way. If you go and set up your orders in this way, then it will take you less time each time you do it from then on. And I understand that concept so well. The how do we do anything that saves you time, tips and tricks for all of the steps we do in our day. There's so many. If we bring up a blank form each time and start ticking things off, that compounds over our day.
Yeah, and I think the other um, insight that I had several years ago now, and it was with my one of my partners in crime who was at another health system as a CMIO, was, if you get a bunch of CMIOs in the room, they'll tell you that if you look at folks that are struggling on a continuum, we've all had the experience that those that were in, let's say, the most struggling decile, right? And I feel for these people because I see what their work-life balance is, and it's horrible and it's not sustainable. But if you look at that worst decile, our treatment approach to those folks has always been the same, which is let's send a trainer out. And an experienced CMIO would recognize that those that were often in that most struggling decile or quartile, our treatment wasn't very effective, right?
Mhm.
Because many of those people knew they had the skills to operate the tools. So, but they didn't have the mindset, right, of how are we going to re-engineer their practice and utilize their entire team. So we went deep on this. We've presented it on a few times, but basically we said, you know, let's generate a phenotype of, is this a skill set problem or a mindset problem? Because those have different treatments, right? Now,
Yes.
um, the problem was I had one hammer, which was, trainers. That was my treatment option, and we knew it didn't work. So we've now we can kind of look at the user action log data, and oftentimes I can actually diagnose somebody beforehand as a,
Mhm.
you need skill set help versus mindset help. And I'm very blessed here that I have such a great wellness team and coaching resources. Now my training team would say, yeah, we know we've been doing coaching for a while. We just can't call it that. But I think you'd probably recognize is that it's often not a skill set problem. Like the skill set's actually the easy part. It's the mindset and team-based approach, and that just taking some time to redesign the workflows.
Yeah, I see what you mean. So if if you have a team member who can be helpful, but you don't trust them, don't work well with them, don't hand those items onto them, then you're going to
Right.
be doing more of the work yourself. Is that sort of an example?
Absolutely. And we have one of my favorite examples is from my office mate. So when I'm in clinic, I share an office with a lovely general pediatrician, and she demonstrated the most amazing behavior one day. So um, while we're both staring at a computer, she just said, "Oh my gosh, can you believe this ridiculous message I just got from a patient?" And she read it to me. And the message was essentially, hey, Dr. So and so, I'm on my way to the pharmacy. Make sure that refill's ready in 15 minutes. And she said, can you believe that? And she took the time to say, I'm not going to respond to this because if I do, I'm training the patient that we provide 24/7 concierge medicine, which sadly we can't, we're not
Mhm.
structured to do. So she said, and she said this all out loud. She goes, the fastest thing for me to do would just be hit refill and be done with it. She goes, but I'm going to close this down. I'm going to go back to my in-person appointments because I don't want that to be the expectation. And I'll get to that tomorrow. And at the time, I will reset those expectations with my patient. And then the nurse came in and she very respectfully said, by the way, in the future, when you get those, you can respond to the patient that, yes, we will get to this in the next 2 business days. Right. So again, empowering her team to do something in the future, and also setting appropriate expectations with the patient. I mean, that's a mindset that will help her practice going forward.
Got it. Okay, so she develops a dot phrase saying, "Thank you for your request. Our team deals with that within 2 days," and forwards it to the nurse. Is that how that
No,
works?
actually, I would take it one step further. So she doesn't want to even get those messages, right?
Totally. I don't want to get those
She
messages.
wants the nurse to have that dot phrase
Yes.
and have a quick reply from the nurse. Hey, we got your message, because it's important to, say we acknowledge your message, set
Mhm.
some expectations. And, I tell my folks, I do not want you looking at patient messages on nights and weekends and on vacation. That's, we have pools for that, and we've got to set up our practices, because you need time. You need that time off to recharge.
Okay, so that's wonderful when it works, and I'm so happy your organization does that because I hear a lot of no, we're expected to check our messages. We have to check them every 24 hours. Even if I'm away, there's no one else who can do it for me. And I'm like, oh boy. So we developed locally that if I was away, I would direct my message box to somebody else for the time I was away, and then they would defer it back to me
Right,
when I got back. But it was another physician level. We had nobody else other than the physicians looking at the inbox. At that time, it was new to the area, and that was the way. We didn't have anyone in between us,
right.
patient to us, results to us, messages to us. Yeah.
And that's it's a bit of a cultural change. It is, but it's a design philosophy that I think, well, and honestly, not everybody agrees. I have other colleagues that are very frustrated that their messages go to the team and not to them directly. So it's so much of this is how we're trained as individuals, but then we go work usually in a team setting.
Mm.
Uh, but it's interesting you brought up the kind of, what is the expectation of the administration on
Mm.
response to those messages. And it's led me to, it was part of my talk last week, because there is that sense, and actually nobody knows where it comes from, but all the new providers think that they're supposed to reply within 48 hours or they're on the naughty list. Um,
Mm.
so one of my discussions during our new provider bring back is, that is not true. First of all, that does not exist. We expect you to prioritize inpatient care, and those messages are dealt with by the team, and we do not expect you to do that on nights and weekends. And we've started adding, which is sad, a sad state of affairs. And as a naive pediatrician, I didn't always appreciate this. But we realized during one of our satisfaction and wellness surveys recently that people were getting berated, frankly, by patients, often in a asynchronous message fashion.
Mm.
It's amazing how rude somebody will be typing versus talking.
Yep.
And we have actually given our folks permission to, when it is inappropriate, to disengage and tell the patient that that's not appropriate behavior. Now, we want to give people grace, because we understand that they may be ill and they're sick. Like, you get a little bit of grace. Um, but it's an ongoing challenge. I will tell you, if you came to my area and you signed up for our My Chart, our patient portal, um, a week after you signed up, you would receive a letter signed by our chief medical officer and our chief physician, or our CEO, who is a physician. And part of that letter would say that we prioritize inpatient scheduled care, or I'm sorry, in-person
Yeah.
scheduled care. And we do our best to respond to messages, but we don't always get to them. So we do a lot of expectation setting on behalf of our providers for the patient. The last little tweak that we did, and I stole this from colleagues in Utah, is it, it used to say, if you were sending me a message to Dr. Mahnke, right? And we stole a simple change. You ready for it? It says message to Dr. Mahnke's office, right?
Mm.
Setting it, I mean, there is no clinic that I know of where you can walk in the front door of the clinic and immediately into the provider's office, right? We
Yeah.
have staged this not because we're all high and mighty, but because that is the efficient way of using our team. And yet this concept that we would do that in an electronic form is silly. So we stopped doing
Oh,
it.
100% it's
Yeah.
silly. We none of us like the direct to doctor message.
Right.
The
I mean, again, if you have a
not
concierge
for me
service
at
and you're,
all.
yeah, if you get paid a ton of money and you have 100 patients on your panel doing concierge medicine, what more power to you, first of all. But our mission is to serve our community, and we eh, we designed it to something that made sense versus just turning it on. So that's
Yeah.
where I'm pretty sure my organization values that my team of making sure we actually think about this, because there's obviously downstream consequences.
Yeah. Talk to us about AI and how it is being developed within some of these systems.
Um, I love talking about this most days. I jokingly say I'm the chief AI officer lately because that is a big part of the work that I get to do. It is fascinating. I think it is this um, concept that is not perfectly understood and yet seen as this might be the lifeline that keeps me going. So we have to be thoughtful and careful about it.
Mm.
That said, the use case that is a incredible use case, which is ambient dictation or ambient documentation, um, is truly a game changer. And I say that partly because at least once a week I get an email saying this is a game changer.
Mm.
So the first technology that I've ever gotten to deploy that people high five me and thank me. And the other thing that's amazing is they do it on day one. It is so there is almost no learning curve. It's not for everybody, but it can be quite impactful, um,
Mm-hmm.
both for the providers, but I didn't appreciate this, or I just didn't think about it enough. The patient experience is so much better because it allows the provider patient to have a conversation the way that we want as a patient. So I get almost as many positive comments from patients that have had that experience with their provider as I do with providers.
Yeah. I think some of the places are there. So we've got the scribing, AI scribing, and it's coming along. I think there's still some areas where it's not for everybody. I think one, it's written not in your voice, and it just takes you that little bit longer to reorientate yourself to what was going on last time when you're reading this
Mm.
notation that wasn't written by you. And
Yes.
when you've had scribes, you've had the same experience. Um, the second thing I see about AI scribing is the you're halfway through a conversation, you're like, did I ask that already? Because we're so used to writing it down as we go. We're like,
Right.
oh, we already covered that, so now we're going to cover it again because we can't
Yeah.
necessarily see the AI happening in the background, so we can't notice what we've already done, notice the work in real time.
Yeah, I actually have not heard that one, Sarah. So thank you. I'm going to take that tip to my group of I've got about a third of my providers utilizing it now. More will come on board when we bring it into inpatient settings, and it only works on Apple devices currently. Um, I, the the voice thing is interesting, and I 100% agree that if it was in your own voice, it was better. It would be better.
Well, when as you're writing your own note, like you've always written your own note in a certain way, and it reminds you, got your mental hooks, your concise summary, your, the way you've always written it, you're like, "Duh, duh, 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 yep, I know what was going on last time."
Agreed, because you're often writing it. One of the recipients of your note is your future self.
That's right.
Um, that said, it reminds me of a concept that we've also focused on here, is that B minus work is just fine, right? And
Yep.
that's a mindset issue. So um, my colleague Chris Kelly and I, different organizations, have looked at what's called the Levenstein distance or the edit distance. So let's say you write a note, or Ambient spits out a note that's 2,000 characters long.
Hmm.
I can actually measure how many characters you changed when you went back and edited that. Um, I think an edit distance of 0 is probably not appropriate, right? I think it's not perfect.
Because it
Um,
makes things up still.
yeah, so I people that have an edit distance of 0, I have a call with, because I'm going to make sure we're not being lazy. We have to be um, precise. But the mindset folks are, and this happens regularly, they will have a 2,000 character note that ambient spits out, and the edit distance will be 2,000 characters, right? So one, ambient's not helping them. And that's it. I mean, that's the single diagnostic test for, we have a mindset issue, that like maybe B- work is okay. So there's a gradation there. Totally agree. It will get better in your own voice though.
Yeah, yeah. How is AI coming into other ways we work within the EMR? So, for instance, when I get the letter from the cardiologist and it's 3 pages long, and there's a couple of things I want to take from that and put into the cumulative patient profile or the past medical history. Say they've got a new diagnosis and I want to update the med list with the new medication change that was given as a recommendation by the cardiologist.
Yeah.
I do that as part of my workflow when I'm looking at my inbox. So I'm looking at that letter and I'm updating the patient on a different screen because, or like in a different window,
Yeah.
because I'm not going to do work twice and I'm not going to go back into that letter with the patient in front of me because it's too long. It's 3 pages long. It's too long. So I'm doing that in real time to save my future self a whole lot of time when I see the patient, right? Boom, 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 done. I want AI to read that letter and pull out the, new aortic stenosis, pop into
Yes.
the diagnostic of the cumulative patient profile. That's where I want to see AI. Like that would be so useful to me.
Yes. Not there yet, but
I know, even if I could
but
just
but getting
highlight the bit,
close.
like highlight the bit and then tell it to put it somewhere,
Right.
even that's a helpful tool because right now I literally have to type it in.
So I think there's 2 points there. One is the interoperability challenge, which I'm not sure we want to get into, but it is honestly continues to be worked. Um, the what I maybe want to start with, which is something that I will tell you. Uh-oh, did I lose you again?
All right, I'm back.
Oh,
So
there you are. So
interoperability challenge.
let's talk about something in that's related to that we're getting value from every day. And I will say I get value because I use this tool every day. And that is AI summarization, right?
Mm,
So it's not quite getting it there. I'll come back to that in a second. But I recently diagnosed a family with a rare form of muscular dystrophy that results in a cardiomyopathy. And they have to see a lot of other specialists. Um, I don't want to read every single line of all of those specialty notes, right? I mean, um, the literally 35,000 beautifully written note from the geneticist, only about 2 lines is relevant.
mhm,
Um, so over the last year now, we have had note and now really chart summarization that allows me to catch up on a patient since I've last seen them, that basically looks through the notes, summarizes it. Obviously the fear is this incorrect? One, it's rare. Well, actually, we found 0 cases when we validated this, but there can be edge cases. But it's also, there's reference. So
mhm,
the summary may have a sentence with a reference that I can click on either to validate or to learn more. Uh,
mhm,
so it's very well referenced. And the beauty of it, and I'll tell you, about a month ago, it got so much better, and I'll tell you how it did it. But one, it knows I'm a pediatric cardiologist, so it takes into account my specialty, which is really helpful.
mhm,
It recently just took in the reason for visit, right? So it knew I was a pediatric cardiologist, but it would bring in some other things, I think, because it just said pediatrician. Now it says they're there for chest pain, and it is a hyper focused summary with references that I might use to start my documentation, because you know what, it's a really nice summary that's already there. Um,
mhm.
so that's where we are currently, and we've got something on the inpatient side as well. We've deployed that to all our providers, and it's gone swimmingly. I mean, it's a very nice to have because one, we have a tremendous amount of data in the EHR, and two, it's all over the place, right? Scattered
Yeah,
everywhere. Uh,
totally. I 100% agree.
yeah. I suspect within the next year we will have, because others, I mean, this is live in other organizations, starting to, one, at the point of care, tee up those orders and tee up those diagnoses, which then will flow downstream into um, the primary care folks kind of view. Now, is it going to work on a colleague, or if I get a referral from a place that is on a different EHR? Probably not.
Mhm.
And that's a huge challenge from an interoperability standpoint. It works if there is discrete data, and we're starting to see that now, where it can take a transcript, right, of the note and
Mhm.
start to extract those things so that it's in, let's say, a machine readable format that then can be exchanged much better, much more easily. So it's it's some progress. I always challenge my colleagues in that we collectively have to decide how much automation we want in that space, right? So I'll give you an example. We do have actually quite good interoperability with problems, medications, and allergies in our state, but only if somebody takes a moment to reconcile it from the other organization,
Mm.
right? So if a medication comes across, it actually technically is not in my system unless a provider says, yep, I'm going to validate that.
Mhm.
Now, we've required that validation, right? And you could put 100 of us in a room and you'd probably get 100 different opinions on, well, that should come over, that shouldn't come over. Uh,
True.
so there's a quality and safety piece, which is in our hands as the clinicians to say, okay, what is going to be automatically kind of put in there and what's not, because there
Is
are,
it visible in the medication list, like, but ghosted, so that you can see that it's not actually been validated, but it's been provided by someone else? And
yes,
so this would be something to think about for this patient.
yes,
Or is
although
it sitting in
it's
a it's sitting in a bucket that I have to go look at to see if there's something to come into this patient's chart that's not yet validated? Because that's what I experience in my current EHR, is there's something that's come in, but it's
mhm.
not yet been seen by a provider. So it's not in the chart even as a ghosted form. It's just, it requires my brain to think about looking in the box that hasn't arrived yet. And it just frustrates. It's just
So
another
I,
thing to
I
remember.
one I 100% agree. And probably 20 years ago, when Epic was designing their interoperability platform, they made they, and likely with a bunch of providers in the room, made the decision that we're going to put that in a separate place. I will give them credit in that about 6 to 7 years ago, they realized, whoops, that was a big mistake.
Yeah, because
So
you can't see
now,
it.
right. So we have moved over the last 5 years, we've progressively moved things in line. So you'll see them, I like your term ghosted, right? They're they're kind of grayed out, but they're
They're
right
grayed
next
out.
to the
Yeah.
other medication. You don't
Yes.
have to go find that. So they call that design philosophy happy together. And it's lovely because I just want to, we have it for the notes now. So my notes are in reverse chronological order. Doesn't matter if they were seen in my organization, because for me to do my job, it doesn't matter. I just want to flip through the documentation that is so important for us to do our job. So it's
Yeah.
getting better now. That it doesn't, and I've had this conversation. Um, a uh, Something came in, an A1C value came in, but our system was recommending that they get another A1C, and they're like, "But I can see it; it's right there, the A1C." Well, it's there, but I like your term ghosted because it's there for you to see it, but we currently do not allow auto reconciliation of that because for the moment, we feel that
Mhm.
that is not a safe practice. Now, that's a debatable item. I will tell you, my one of my colleagues in Ohio, they automatically reconcile that so that the decision support can
Mhm.
know that. And I'll tell you the funny story. All of a sudden, they got all these alerts for elevated A1Cs. Well, that's because one organization mapped average glucose from a continuous glucose monitor to the A1C. So all of a sudden, everybody had an A1C of 150. So, it's tough.
Yeah, the knock-on effect when you decide to make a decision, which is the hard part of being in leadership.
Yes, but it's fun too.
You're like, sorry.
Yeah.
Okay, any take-home tips, anything we didn't talk about that we should talk about before we end the show today?
No, I think, we've touched on most of this. I'd have to recognize that the good stuff that comes out of our organization is 99% my team, and partnering with our operational folks and our providers. And again, it's not the providers. We take the team-based approach. I tell people that CMIO is my title, but it's not the right title because they assume that the M stands for MD or physician only. And I have annoyed some of my physician colleagues who have come to me and said, your job as CMIO is to make sure I do the least amount of work and it goes to everybody else. And I laugh and I say, oh, that's actually not my job. It's a team-based approach, with thoughtful design, right?
Mm.
So that we can provide healthcare. And I'm pretty sure I went to a medical school, not a healthcare school. And turns out those are very different things,
Mhm.
and a very different skill set. So we enjoy taking that approach at the team level to ensure that we're all healthy and hopefully our patients are healthy as well.
Very good. How do people reach out to you if they're interested, just to know where to kind of find you in the world? If they're also a
Uh,
CMIO or they're trying to do some of this
You
work
can
at the
find
moment.
me on LinkedIn. Mahnke and is not a very common last name, so it's pretty easy to find me at Becket Mahnke on LinkedIn, or at Confluence Health. I'm pretty sure you can find me just on the confluencehealth.org website. But always happy to chat with folks, with you and others. I tell people I've never invented anything. I've just stolen from a bunch of smart people. So if I can share some of those robberies with others, I'm happy to do so.
Yeah, and I'm happy for this conversation to say that while we all get frustrated with our EHRs, I think it's nice to know there's systems, there's people, there's teams thinking about us too, not just patient quality care, not just how we put information in and get information out, but also the actual end user is thought of at times.
If the leadership, that values it. And I'm very blessed that my leadership very much values the work that my team and I do.
Yeah, love that. Well, thank you so much for this conversation.
Yeah.
Have a good day.
All right. Bye-bye.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.